kick back and say that, you were oversized with the stent. But the problem comes because what you have here is a tapering vessel. And the critical part is, how do you size in a tapering vessel? Should you do it to the reference diameter of the proximal segment or the distal, or something in between? And particular care needs to be taken. I think one of the issues which happened is you were slightly oversized and the lesion was slightly on a bend, which made it little. Now, going back to the covered stent, whenever you're deploying a covered stent, please understand this is like the first generation of a stent. This does not track nicely. This is not an easy thing to use. Be prepared. Often you may have to deep throat the guiding catheter to get the covered stent in is much harder. Now, the last part is, what is going to be the follow-up for this patient?
Patient still has effort angina. He's on medical treatment.
Now, how would you, chances are there are going to be long-term issues with the covered stent, including a much higher rate of restenosis. How do you plan to tackle that? And has the patient been educated about the possibilities of some of these?
I think in the last angiogram we can see that there is almost nil distal flow. There isn't much question of a restenosis.
I would like to make one comment. Yeah, but you'll be surprised. He may regain some flow subsequently, but let's Mark, hold on your question. First there was a question in the back. If somebody was standing up, yeah. Please go ahead, and Mark will take you immediately after this.
Sorry, but we kept a possibility of oversizing of stent. But 2.75, if we say was oversized, how could it accommodate 3 size of covered stent? So maybe the thing was that the placement was wrong. It was placed at a bend.
Exactly right, which is why I said I am not 100% sure, and it's very difficult to size it in a tapering vessel. Mark?
Samir, can I make a comment?
Please, yeah. Hold on just 1 second. Let's take it in the order. Yeah.
Two points. We are in an interventional session, but I want to come back first to the indication. It's a CTO. It's quite, we can say, a single vessel. We have a tight diagonal, but it's a small branch. As you said, at the end of the procedure, the patient is completely asymptomatic, but the circ is still 100% blocked. So I want to point out the fact that before to attempt a CTO, we are, of course, we have to be sure there is a large ischemia, because we know that the complication rate is higher. And with the optimal medical therapy, I am an interventional like you, I like to open CTO, but we have to consider the risk of complication rate, which is much higher before starting such a procedure, because the patient can be totally asymptomatic with the beta blockers and optimal medical therapy, only with the circumflex. And the second point is technical. I think the why should have gone in the marginal. There is a marginal which is very difficult to see, and just by predilate with the small balloon before stenting was the key to avoid a kind of complication.
Regarding the first point, this particular patient was a manual laborer and he depended on the manual work for his survival. So even though the area of jeopardized myocardium wasn't large, the indication was that an open circ would have given him, allowed him to go back to his work. That was why we took him up, even though the...
No, this is not...
observations, Mark, I kind of agree with you. Hold on 1 second, please go ahead.
In continuation of what Dr. Mark has spoke, whenever you deal with such small vessels, I think the first thing we should use a smaller balloon, then take a shoot. If you see the angiogram, the wire was just going. There was no flow in that vessel. In fact, you should have withdrawn the balloon and re-injected whether the other OM, which was bigger, is patent. Then you would have rewired the other OM and then decided about the stent size.
Good observation.
The other point is the major problem came when he is pulling the thrombus from the circ into the LAD. Because this happens many times when the covered stent is there, when the balloon, when you're in a hurry, pushing and pulling, and then you withdraw a thrombus into the LAD, and then the whole hemodynamics changes.
I want to emphasize what I had mentioned before. Because often what happens when there is inadequate sealing of a perforation, that's because the duration of balloon inflation has not been long to tamponade, which is, and it often happens because the patient gets ischemic. So again, in your point, and you also actually had a slight ostial disease of the left main. So come back with the guiding catheter that enables you to give prolonged balloon inflation. Questions here, Mark?
I just want to say the same. I didn't do any laser at this time, but before the stent era, we used to leave the balloon for 20 minutes to seal the dissections. we used to put a perfusion balloon, and the average time to seal a dissection or a rupture is about 20 minutes. So don't be afraid to leave a balloon for 20 minutes.
More observations?
Dr. Mehta has mentioned that
One second, sir. One second.
It was sudden tapering. I don't think it was sudden tapering. In all CTOs, you must review the film correctly, properly, and for a prolonged period of time. There was a vein which was feeling retrogradely from the LED. Actually, that was the main branch, and that was CTO, and this one was the minor branch. Second comment is putting a covered stent in a 1.5 is not the right choice. Should have put a coil there, sort of knocked off the wave total, because the CTO is not serving any purpose. Thank you.
Can we put an arterial...
Can we have the lights back first in the room, please? Yeah, go ahead, please.
Can we use an arterial embolization with the glue in this situation, because we have tackled one case like that?
Right. Again, one of the options, not most places are going to be having it. You need to be much faster. The level of expertise has to be much, and I think a balloon is always the best option. I think a covered stent should be the second option. Coiling may also be a possibility. Glue is as a last option, really.
Because
the lights back, please.
We had in our place,
yes?
for a meeting with a large kidney tumor, we usually embolize the artery, then we can remove the tumor.
Excellent.
Same glue we used in one case, and it got arrested.
Wonderful.
Regarding glue, you need to be really expert. We don't use it regularly. So if you have a good colleague of yours who is a neurointervention radiologist or radiologist, you take his help. It's not very easy to use glue. The moment you inject, you have to remove the catheter immediately. And sometimes they have a lot of broken catheters, so you can't leave a broken catheters. So when they do this in renal embolization, renal perforation, the catheter gets break and they just leave the catheters like that. So glue is an option, but it should be one of the last options. As Dr. Samir said, prolonged balloon dilatation, covered stent, then probably coils, then probably glues.
Yeah, one last question, please. Go ahead. Hold on, let's get you the mic, please.
Currently, we do not have the perfusion balloon catheters available. And to keep the balloon for a prolonged time in a viable territory...
Just hold your comment further. 1 second. The technique I mentioned converts a regular balloon into a perfusion balloon once you've taken the guiding catheter outside. The key being that be sure that wire has been secured very nicely, and be careful, not that, when you are... See, it has to be a very gentle thing. You've got the balloon inflated there, not at the highest, and you slightly remove the guiding catheter and be sure that, the whole system does not back up.
But how the distal perfusion to the muscles will be maintained, even if you put the guiding catheter out, you occluded the blood flow to the distal bed,
I have no... You're right about it. Often you need to put it back. At that point, you are much more concerned about sealing it adequately rather than worrying about... Of course, a lot of these patients get very ischemic.
Because I had a case where I had a LED perforation in a normal LV. Despite putting 2 covered stents, the perforation was not sealed. And had such a long time, the patient was bleeding. I could not keep the balloon occluded for a long time. Because the patient would get chest pain, go into ventricular arrhythmias, and she was intubated and all that. Ultimately, I had to send the patient for surgery. So I feel that perfusion balloon catheter still has a role and must be available for cases like this.
One of your last point is a very good one. We used to have virtually a protocol, and one of the first things that's done is to try to be sure that you have a surgical option available. Once again, thank you for an excellent presentation, very well managed case, and let's move to the next one.